This is me in the lab teaching some fellows recently. So just mark the superior pole of the patella, and I leave a finger's breadth, about a centimetre, put a little dot there, and I've now moved to a longitudinal incision, about 2 to 3 centimetres, made it a bit bigger here just for the demonstration. And you go through the skin and you want to excise the fat pad. And the one thing I would tell you is to try and get that fat pad out in one piece. It's a real pain if it starts to fragment. And once you've got that out, then actually you've got quite a clear view. This is me in theatre. What I'll then do is use a cob and a swab, or your finger. In the cadaver there's not many adhesions. And by the longitudinal incision, you can see where the tendon's running. So, because it doesn't run straight. What I then do is I take a double-bladed knife just to score some tram lines to start you off, to make sure that it's going to run straight and that you're angled, because it's running laterally, not straight up. I then just take a 15 blade and free up each edge, just a distal 2 centimetres, and I take a full thickness graft. You can see just by bending the knee there, the skin moves, you move your Langenbeck, so you get a nice view there, and you just free it up. And I always take a full thickness graft, get it off there, and then pass a loop suture around it. I use a fibre loop. One on a straight needle is really helpful. And the reason being that straight needle, just the weight of that will help pass it, just drop it through your harvester. And then you cut the needle off. And the one thing is, when you do those tram lines, you try and taper them if you can. Here I haven't quite tapered it sufficiently. You can see I've got tissue that's blocking me. So sometimes you've got to just trim off a bit of tissue. And then with maintaining some gentle tension on the sutures in one hand, you just advance it in the same direction, sustain pressure, quarter turns, a millimetre forward at a time. And actually in real life it goes really quite easily once it starts to go. I go to 70 mil rather than 65. You can comfortably get to 80 on this, 85. And 70 gives me, you can see I've got it's full of tissue. As I bring it back, you retrieve the sutures through that little window. You'll retrieve the graft through the window as well. And then you go back up to 70, and it will just slide down there. And you sustain that pressure in your left hand, push rod goes in. And in the theatre case, if you just extend the knee slightly, it goes pop. And then in the cadera it doesn't matter so much, and you cut it off. And what you get is a real solid tube of collagen, and that's what I really like about it. That's the defect I'm going to close. It closes, put a swab in there, it's pretty waterproof, and you get a good closure of that, and that's the graft. And what I cut off the end 5 millimetres, so I've got 65 millimetres of solid 10 mil tissue.